And the Gravity Project is honored to welcome you all to our first public collective call of the 2021 year. Thank you all for your efforts over 2020. It was a big year. There's a little bit of revision today and a little bit of looking forward, lots of announcements. And I look forward to the call. So next slide, please. Again, so this is welcome. This is Sarah DeSilvi. If those of you don't know me, I'm the director of the Clinical Informatics Terminology wing of the Gravity Project. The different wings, we'll talk about them briefly as we go into the call. Thank you for joining our meeting today. Due to the large number of attendees, we always mute all attendees upon entry because although there's about 40 some odd folks today, usually we get up to about 100 attendees. The call is recorded always, and recordings are always available on the Gravity Confluence page following the meeting. I work hard to work the chat as if we're having a public conversation, and then we actively unmute if there's critical points that need to be discussed collectively. So if you have any thoughts that you feel like need to be addressed, please do not hesitate to put them into the chat and we'll work them in real time. There are question pauses built in at the end, or at least we try to do that. And please send all chats to everybody so everybody can see them. Next slide, please. This is a every day, every meeting statement of our Gravity antitrust practices. Next slide, please. Just going to officially not just welcome you, but invite you to join the project. As we go through the talk, you will see that the links that we reference in the discussion are putting into the chat. So if you see, for instance, the first link is to officially join the project, that link is now in the chat. And if you want to check whether you've already signed up or if others from your organization have signed up, you can review membership in the next link. And then the Confluence is always a plethora of information on the Gravity Project, both of our wings and all of our policy initiatives and announcements from our critical partners. It's all available at that last link there. Next slide, please. Just every meeting thank you to all of the folks who lean in. Of course, we're very grateful for every single one of our members. This is a slide that highlights individuals who've offered in-kind support, grants, and founders and funders. So thank you again for all of the folks who are leaning in this way for the Gravity Project work. Next slide, please. And then if you go to the Gravity Project sponsors link, there's information on becoming a sponsor yourself, and we'll talk more about that in a bit. So this is our agenda for the day. We're going to go through announcements, which are principally myself, and maybe we'll have Evelyn on the call and she can lean in if so. Because it's the first call of 2021, I wanted to just ground some of our members in our general process. We're working on creating baseline education just to make sure that everyone knows what we're doing and everyone knows how to find references if needed. I'll go into a schedule update as we kind of approach our project through an agile project management perspective. Mark, our policy lead, Mark Savage, will discuss the USCDI submission. We're then going to go into kind of updates on all of the elements of the domains that some of them are carrying over from 2020, because as you remember, we focused very intently on that ICD-10 CM submission. So we have some continued work in inadequate housing, transportation, and financial strain, and then our other domains such as education, employment, and veteran status. Our last element of the conversation will always be a summary statement of community homeworks and next steps. This meeting might go over our hour-long mark into the hour-and-a-half long mark just because of the breadth of things we have to discuss today in the call. Next slide, please. Announcements. Next slide. Again, as I mentioned, so if you are interested or your organization is interested in sponsoring the work of the Gravity Project, you can find information about that at this link through the Confluence. Our partners at EMI Advisors, who are program management and project management allies with Evelyn Gallego and Carrie Lausberg and Sarah Bahal, and Linda Hyde through Terminology. You can directly email about sponsorship Gravity Project at emiadvisors.net if desired. Next slide, please. Just a reminder that as this is kind of the public call and we focus on everything and largely on the terminology work, on Wednesdays from 3 to 4 Eastern Standard Time is the HL7 Social Determinants of Health IG public meetings. You can find the meeting calendar at the link there. So that meeting is when Bob Dieterle runs through, our technical director runs through elements of the IG build and updates about things like the Connect-a-thon that are coming up shortly. So we encourage everyone to call. Yes, so Carrie, we're going to go into that in a second. Absolutely. So we're going to talk about the goals and interventions work group and ways to help our community members in that ask. Absolutely. Next slide, please. This is our Connect-a-thon is next week. So the next Connect-a-thon is on January 13th through 15th. The Gravity team's leading our Connect-a-thon track. There's the focus of the Connect-a-thon track is 1, exchange and update interventions, and 2, exchange of observations, conditions, and goals. You can see the Connect-a-thon track page at this first link. You can sign up to be a participant at the second link, and you can see the Connect-a-thon page at this last link. Next slide, please. Here's another update. So we tried to post opportunities for fellowships and grants that are aligned with our initiative. Is Evelyn on the call here today?
Yes, I'm here.
Hi, Evelyn. Do you want to speak to this fellowship opportunity?
This is the NCQA one, right? Sorry, I'm multitasking today, driving.
Do you want me? I'll speak to it then.
Yeah, no, it's fine. I know it's just the NCQA nationally. And now I'm forgetting the acronym.
The Healthcare Quality and Equity Fellowship.
So we want to acknowledge they're very supportive of the Gravity Project. They actually have membership on our Strategic Advisory Committee. They have a fellowship available, and so they've asked us to circulate because it's very much focused on the work we do, so building on the work we do within the Gravity Project. And so please, we just want to encourage our community to apply if they're interested in the opportunity.
Yes, and we are very, very grateful. And Carrie Christensen is on the call and directly gave her contact information regarding the fellowship opportunity. There will be information about this on Confluence, and as always, if you don't catch Carrie's email in the chat, you can always email gravityproject at emiadvisors.net, and we will connect you. Next slide, please. So this is again in reference. So you all likely remember that the Gravity Project submitted our multi-domain ICD-10 CM concepts on Friday, December 4th, 2020 to the ICD-10 Coordination and Maintenance Committee meeting. You can view the submission on the Confluence. It was the summary effort of all of our collective work. The next step is for that submission to be reviewed at the March 9th ICD-10 CM Coordination and Maintenance Committee meeting. We're actively seeking letters of support. So if you wish to send a letter of support to NCHS, you can send it directly. There's an NCHS ICD-10 CM committee email, and you can always find further information regarding the application itself and the submission itself and the comment process on the Confluence. We're hoping to get our comments and letters of support in early by the end of January, just to create the kind of groundswell about the application needing to be heard in March. Next slide, please. So I believe, so Mark, are you going to speak to this briefly? Would you like to? I put you on the spot, friend. I'm sorry. Mark Savage, are you muted? I just saw. I'll speak to it then. So,
No,
CM
I'm now unmuted if that helps you.
oh, wonderful. Mark, would you like to speak to this slide since it
Sure.
was such an amazing effort on your part and we're grateful?
It was a Gravity team effort. So,
Yes. Yeah.
Centers for Medicare and Medicaid Services issued a proposed regulation and asked for immediate feedback. It was published on December 18th. And while it was a broad regulation, it included a particular piece about social determinants and social risk data, which it called a request for information. And they asked some specific questions about barriers and challenges to standardization and exchange of social determinant data. Sort of core to our work, and we worked quickly over the holiday from the 18th to the deadline for submission, January 4th, and got a set of prepared responses together. And we submitted the letter on the 4th. You see the link there if you want to go take a look at it. And I was poking around and happened to check some of the other letters, and just an amazing affirmation for the Gravity community and all the work that you are doing. There were 31 letters at my last count that also to CMS that also explicitly mentioned and supported the Gravity Project's work to standardize social determinant data and to make it available for helping with social risk. So another great effort from the team. Thanks, Sarah.
Thank you, Mark. Again, it's just proving our broad collective is a wonderful group. And thank you for that quick turnaround, Mark. You did a really good job helping us there. Next slide, please. We do want to state that, it took us a little bit to get it out, but we do have a press release regarding our food insecurity complete data set from last year. You can see the press release there, and if you have avenues to share it, please share it far and wide. Look forward to new press releases coming regarding some of our critical updates that happened in the end of 2020, including the ICD-10 submission. So we should be working on that and getting that out to you ASAP. Next slide, please. I wanted to give an update to everybody, and I mentioned this early. So over the break, while our meetings were quiet, we worked to kind of true up some education regarding what we do. So we have a few new educational pieces available on the Confluence in our educational and instructional materials section of the Confluence. One is a general overview of the terminology process. So this is basically from the start to the finish about how we collectively come to agreement about terminology elements, about everything from our literature reviews and our analyses of existing processes to the application for new terminology. And then we also created a video describing the adjudication process. It's very informal, it's myself. So just basically trying to let anyone know how we go through the process of adjudicating to judge whether our data components that we suggest in the community are in or out of our master data set. So you can find these elements again on the Confluence. The aim is to create as many educational materials as we can so that these can be disseminated and shared both within and outside of the Gravity community. Next slide, please. Again, so this is just a brief view into some of the elements that came out of the educational process. Next slide. So you can see there's been a few updates here in our Gravity overview model. So this is the model that describes the terminology division and the technical division. So terminology is the work that I lead with my colleague Linda Hyde, and then technical is led by my colleague Bob Dieterle. The name just changed here because it's definitely terminology and not just regarding social determinant domains, because domain work is carried across both streams of work. Next slide, please. We also kind of updated our growing list of domains that we cover. We still were using our slide that just had our inaugural year domains, food insecurity, housing insecurity, and transportation insecurity. So we're trying to create space not just for the concepts we're actively working on, but those concepts that are in our parking lot, as we call them, for collaboration on in future work in 2021 and beyond. Next slide, please. We also added a section for analyzing, which we had a critical kind of gap analysis element that was missing from our work, because as we create our master data sets collectively, some of that terminology is already built into US terminology standards and some is not. So there's a gap analysis section where the team internally works to look at what needs to be built and then submits those elements to our terminology organizations. Next slide, please. And then I just wanted to ground everybody, and I think I'm going to try to do this every meeting, in our Gravity use cases. They're really critical for understanding the goal and intent of the work that we do to collectively. So our 3 Gravity use cases as they stand right now are documenting social determinant data in conjunction with the patient encounter. Again, these are the considerations we have in mind when we're doing our work. The next is documenting and tracking social determinant related interventions to completion, and this includes necessarily our collaboration with our community partners, both from a process perspective and a technical perspective. And then the last is gathering and aggregating social determinant data for uses beyond the point of care. So population health management, quality reporting, this is where we collaborate with our wonderful friends at NCQA and beyond, and risk adjustment and risk stratification. And you can remember these elements, risk being critical elements as we considered necessary ICD-10. Next slide, please. Any questions from the announcement and grounding section before we go into schedule update? Okay, so some updates to the schedule. Next slide, please. I took some time to try to create a little bit of clarity in our project schedule. Our friend Lucy Johns was commenting on this last time as well. So you can see some of the names have been updated on the elements, and some of the things that we've had in Park are now, you can see them populating out in the work in 2021. We are working in collaboration with our friends at NEHI on some of this work. So elements that are, we're focusing specifically just on screening questions and answers and diagnoses are right now in the dotted lines, and elements where we're fully robustly going forward as we at least if we think so, on everything from screening questions and answers to goals and interventions is in solid. Again, everything in time, we will focus on goals and interventions in time. And this is just to kind of help us continue to frame and evolve our roadmap and our schedule as we dive into the domains and some of the subtleties of them get parsed out. Hi, Lucy. No worries to be late. You can see here we are at the break of 2020 into the dawn of 2021. You can see in the technical stream, the IG ballot work and ballot reconciliation, and the Connect-a-thon happening very shortly, as we just discussed. Again, there's a little bit more work and tweaking to be done here on the roadmap and the schedule, but we're trying to make it as easy to understand where we are and what's in store for the community as we go forward. There's some domains here that aren't on the schedule yet that you'll see come over time. Next slide, please. This is an evolved project schedule from what we saw when we last came together, and there's some reasons why. If you might remembered, we were going to vote on the inadequate housing data elements and master set. There's a reason why we're not, and we'll go into that in a second. So today we're covering inadequate housing, just some robust analysis of screening questions and answers. We're discussing our work for goals and interventions across multiple domains, and then really specifically focusing, and this is Carrie, what we'll talk about how to assist any of our partners who are working on the program and project identification list. We'll go into that today. And then we're going to specifically focus on some things that come up as we do an end-to-end review on financial strain and transportation. Your homework is to submit transportation insecurity and financial strain goals and intervention concepts. Over the course of the next days, you'll see master lists that are increasingly more robust for screening and diagnoses comments for a transportation insecurity and financial strain. And then we're asking you to submit, again, just screening and diagnoses across education, veteran status, and employment. Jenny has a question, and Mark, I wonder if you can answer it. When would you project that the ONC might be able to update the USCDI to include additional SDOH concepts?
So we are waiting for ONC to come out with its draft for version 2. That draft will then go through public comment. When then ONC will make a decision about what's included. That decision date is expected to be effective around July 1st if they stick to the previously announced schedule. Of course, nothing precludes anybody from starting to use it right now. Does that answer the question?
I think that's you answer as well as you can, I think. We do have an USCDI update in a couple minutes, so but I just wanted to get to that question.
Thank you.
So you can see, just going forward, the goal is to get to a vote in a month from now. And you can see, because there's a lot of work to do, there's a lot of work that's already been done. There's a lot of stuff to review so far, but we've added possibly, and I think almost certainly, a need for another meeting on the 28th of January, just to be able to review everything on hand. Again, for education, unemployment, and veteran status, really the focus is just on screening questions and answers and diagnoses, and much of that work has already been done. And then for financial strain and transportation insecurity, it's the complete set. So you can see the homework for each of these things aligning with the dates and then moving toward a vote on the 4th of February. There's more USCDI questions, so I think that's our next element on the agenda. So you can go next slide, please. And I think, yeah, hi, Lucy, yes?
Hi, Happy New Year, everybody. I was wondering about connecting our schedule, showing our domains and all of our testing. Connect that to the blog that you published in December about changes in, what is it called, evaluation and management coding, or something to that effect.
Oh, the one I wrote with Laura, yeah.
Yeah. So I'm wondering how these domains and our work get into the discourse in the universe that is now going to be adjusting to coding for social determinants for billing purposes.
So Lucy, clairvoyant as always. So that was kind of the intent of the communication that I'm writing regarding the ICD-10-CM submission, aligning the possibility for a specific social determinant diagnostic language with the new E&M regulations and with a comment on capacity for specifying social risk. So I would love your help in writing that and coming soon to a blog, hopefully near you.
Terrific. I'll certainly do whatever I can to help.
Okay.
The sooner it gets out, you know, those of us who, and there are a lot of people on this call who see the arc of history from thinking about the ideal to actual coding that incorporates the ideal, we know how long it takes. So the more conversation and publicity and marketing and all of those terms, meaning that our conversation gets out into the universe, the more of that and the sooner, the better, because it's going to take a long time for anything that we think is such a wonderful idea to actually get done.
Ditto. Props, yes, Lucy. And this is my weekend homework, so I'll send you a draft to review, and you can help me with it. And anyone else who wants to help, just let me know. So thank you, Lucy, for thinking. Maybe you can help hold me to task on that one too. In the many list of things, Lucy, maybe you can help me make sure that happens in short order. And that's a sincere request, by the way.
Happy to bug you about it. Okay.
Thank you. Yeah, thank you so much. Wonderful. Okay, so we'll start a little separate writing group, and that sounds fantastic. As I saw Lolita's comment. Hi, Lolita. So there's a question regarding changing status from interested party to member. I do believe it's as simple as sending an email to gravity@emiadvisors.net. If it's any, and I do know that if you send an email to that email, anything you desire regarding Gravity can happen, because that gets the attention of the amazing Sarah Bahal, who will be able to help you, who's crucial for everything that happens. Hi, Sarah B. Sarah B. So I would just send to Margaret, I would send an email to Gravity and then go from there. Next slide, please. So Mark, it's you.
Thank you. Next slide. So I will try to give the brief update and then ask Barbara's question, answer Barbara's question in the chat from a minute or so ago. So you have seen most of this before. Gravity Project did make a submission for a new social determinant data class to the Office of the National Coordinator to be included, we hope, in the U.S. Core Data for Interoperability. The update from last time is the amazing number of letters of support that you see down at the bottom of the page. This is over 20, and they are still coming in. And this really makes an impression on the folks at ONC who are considering this alongside a lot of other recommendations for data elements. So thank you so very much. And it's not too late. If you want to submit a letter, just reach out to me, and I'll be happy to help you with the template if you would like. To Barbara's question about whether inclusion in the USCDI helps collection or just sharing, I think the answer is both. The USCDI has a set of standards for capturing representing the data, but it's also within a FHIR framework, a FHIR implementation guide, which helps with the exchange. So that if you've got it in the USCDI, you both have a standardized framework for collecting it and holding it, but also a standardized framework for exchanging it using FHIR API. So, Barbara, I think the answer is both. It's not just one or the other. It's a twofer. Sarah, I think that's it for me.
That sounds wonderful. We love twofers. Thanks, Mark. Buy one, get one free. Next slide, please. Any questions on announcements? It's okay. You saw Carrie. You can add Washington Association of Community Health Centers there, which is thanks, Carrie. Next slide. All right, so now I'm going to go through kind of a level setting of where we are, because we have a lot of work to do this month, and our capacity to do that work really depends on understanding where we are right now and what needs to be done. So first, an update on inadequate housing. Next slide, please. So one of the things that happened as we were kind of taking a breath after ICD-10-CM submission is I did a really formal audit of kind of the master lists as they stand for each of the critical domains. And in inadequate housing, I found that there were some critical questions from the American Housing Survey that would lead to our suggested SNOMED inadequate housing diagnosis suggestions that we didn't have yet. So this is why we paused the vote, because one of the things that Gravity works very hard in is trying to get into the public sphere some of the standardized approaches that our federal partners use, because notably the methodology across many of the screening approaches, whether it be HUD American Housing Survey or the Housing Security Survey and Development or the USDA Food Security Module, are very similar, and they end up inevitably being the gold standard. So in order to ensure that those federal approaches were in our inadequate housing set, we're doing kind of a screening and diagnosis dump, screening question and answer dump over the next few days. That is on my dance card for the next chunk of time, along with my colleague, Linda Hyde. And then we'll be just focusing on reviewing that over the course of the month and then voting on it on the 4th. Just for reference here, I put again the collective diagnoses we came to. Again, these are SNOMED suggestions. We left in ICD 10CM that simple and adequate housing, but within SNOMED, we worked very hard collectively to come up with granular diagnoses that were elements of housing quality. And we just want to ensure that we have screening questions and answers that specifically align to these outcomes. So that is going to be improved over the next week or so. And then Mark, the SEO's data class covers which domains? All of the domains.
So we put in our submission the first 11 domains that we Gravity have been collectively working on. The Gravity community has not finished with those 11 domains, but instead we recommended them as placeholders because we thought we would have finished and provided the necessary detail by the time that ONC makes its decision. We were very clear in our letter to ONC that there are far more than 11 domains, and that we were only presenting for version 2 what we thought we could complete carefully with our good Gravity process, but they would expect to see others from us in the future as well. And I see them there in the chat. Thanks so much to Carly.
And just as you'll see, this kind of ties into the conversation we're having today and other elements. Some of those concepts, as stated, really are apparent concepts for other concepts that exist within them as well. So that's one of the things that Gravity is working on, is clarifying what we mean when we say a domain. And you'll hear that kind of as a theme throughout our work in 2021. As we learn how to do this better a year and a half in. Next slide, please. So,
Sarah?
Hi, Lucy. Yep.
Before you leave this slide, a lot of these items that constitute substandard lend themselves to interpretation rather than a yes/no answer, like lead, say, would be yes or no, I would think. But adequate water, overcrowding, structural insufficiency, does not meet functional needs. Are all of those criteria defined by HUD or by somebody so
Yes.
that everyone's on the same page about what constitutes substandard housing?
Yeah, so part of what the aim is the reason why that audit is so important of the screening questions and answers is there really are best practice questions that lead to these outcomes. So both from a clinical process perspective and a semantic consistency perspective, and from a technical perspective, as we look forward to the implementation guide, it's really important to make sure those questions and answers are in our approach so that we can tag them. So you can imagine just being necessary for consistency in the ecosystem. And yes, 100%. Yes.
Thank you. I was thinking mostly of inadequate water. Does that refer to, for example, temperature and 24/7 availability, and maybe even, or clean? So I'm looking forward to seeing, or maybe somebody could send me a link to where all of this is defined and will be defined. Thank you.
Yeah, so the great thing is you should see, I think there's actually a typo there in my, I don't want to tell you at what time of night I finished these slides last night. So I think the adequate water supply, there's a missing word there. But what you'll see again is the alignment, the logical alignment of the question and its answers and how it links to this. And then, as always, in our references, you can always reference the American Housing Survey methodology and approach, which are very helpful.
Thank you.
Yes. We have a comment about great points, Carly. I was thinking of interpersonal violence. Yes, so we did discuss the intersection of personal safety and housing a lot over 2020, and the qualifications, especially even for HUD homelessness status. So this housing quality is really regarding structure, and then luckily we're addressing interpersonal violence and other domain work. And then we did decide to build a supplemental screener in partnership with our friends at HMIS that we still have to work on, that would allow for the qualifications of interpersonal violence and domestic violence for qualifying for emergency housing. So the intersection, we talk often in Gravity about how we have to kind of sort these domains to create terminology structure, but certainly in the lives of the people we are talking about and the patient stories, many of these things are overlapping. So yes, I hope that was my extemporaneous comment was in reference to something in the chat. Next slide, please. Any questions regarding the work of inadequate housing? Again, the reason why we're not voting on the set as a whole right now is because of just wanting to make sure, as Lucy called to light, that there's really clear alignment with how one would screen for these things. And because of the screening questions and answers, we'll get a very clear operational definition for the diagnoses we're suggesting. Okay, next slide, please. Oh, thank you. That was my thank you to all of you. Thank you to the work on all of that you all did in the 2020. Next slide, please. And thank you to our subject matter experts across all the different domains. We have our subject matter experts across housing security and homelessness, and transportation insecurity and financial insecurity. Again, this is just a smattering of the many individuals who have weighed in with their expertise. George Carter specifically from HUD, but then of course some of the principal researchers in the HUD and homeless housing quality data space had a few huddles with us regarding inadequate housing as well. Next slide, please. All right, so transportation insecurity update. Next slide. You can see that it was both identify and review, because there's a few things to add here. So our definition of transportation insecurity is evolving, of course, and one can always find that in the master as a work in progress. So we're trying to mimic, in some sense, the definition of food insecurity, but understanding that transportation is not just necessarily about the vehicles you drive, so needing to think really comprehensively and globally about what transportation means in a wellness perspective. Next slide, please. And then I wanted to give kind of an update on where we are with transportation and security screening tools. Again, as you look at the master that's blooming over the course of the next days or so, and you think about the work to be done, which is to assess and come to agreement on the fitness of the transportation screening questions, we have so far questions from Health Leads Prepare, the North Carolina Healthy Opportunities Screener, the Washington Association of Community Health Centers, Accountable Health Communities Tool, FENX questions, CUB questions, Promise questions, WellRx questions, questions from the American Academy of Family Physicians, the Upstream Risk Tool, NHIS tool, and then a really lovely transportation barriers measure. So you can see that this has bloomed quite a bit from our last screening questions and answers assessment. Again, if there are tools out there that you do not see here, then please let us know. I do want to state alongside the specific domain work, Gravity is also doing a meta assessment of all of the comprehensive screeners that we've come in contact with over the course of our year and a half, and making a kind of a matrix of all the different domains that they touch. We're going to share this information back with UCSF Siren to help update and augment their table of social risk screeners that they have publicly available on their site. So that matrix in development, and Linda's working hard on that right now. Okay, so Carrie has questions. Okay, Carrie, what's your question regarding screeners?
So we have health centers who are doing iconography for their screeners, and I do not know how to present them.
Do you mean like the Camden card approach, you mean?
Yeah, yeah, they're just icons that patients will circle. I don't know how to present them in a data set. Will you guys have guidance on that?
You know, I think I can work with you specifically. Can we talk about that? Because that's one of the things. I'm a big fan of the Camden card method for both patient-driven assessment of social need, right, versus social risk screening. So I do have some ideas about how one might build that into a method. It's not necessarily going to be LOINC appropriate. Like, I don't know how. We'll have to think about that. We can also work with our friends over at Right Dentistry to figure out whether that's even remotely capable in the LOINC world. But let's have a specific huddle regarding the ICON approach to identifying social needs, because it's definitely critical in the care management holistic social risk perspective. Sound good?
Yeah, that sounds great. Thank you.
Okay. So Jenny, do you have a link to the Siren social risk screeners? When will your summary of the Siren screeners be available? So we can try, oh, look at this. Sarah Arnson coming in with all of her wisdom. LOINC can include images like the faces pain assessment. Thank you, Sarah. So Carrie, that's the answer, and we can work on that together. So I think it's probably just submitting it as a file, and then we can go from there. I always love it when your experts are like right there in the chat. This is the best. And then Jenny, right now I don't have the link to the Siren social risk screeners available. Maybe one of our friends who's kind of working the chat can help. But if it's publicly available, so from the Siren website, and we will make sure, we'll try to get it to you in the chat. And if not, I'll try to send it directly to you after the call. Okay, so basically summary statement, this is where we are with transportation insecurity screening at this time. We are conducting a meta assessment of all of our comprehensive tools that we have, everything from iHelp to SWIC to WeCare to Healthies, Prepare, Health Communities tool, of course, and including necessarily those federal approaches. So wanting to make sure we include the standardized approaches for assessing things like education status and employment in all of the federal approaches, whether it be the current population survey or the American Housing Survey. So that's coming soon to a Gravity resource near you. And EMI, thank you. There it is. There's the social risk resources for the screening tools. Thank you so much, Sarah B, or whoever that was. Carrie, thank you. That's very grateful. All right, next slide, please. Just a review of transportation and security diagnoses. Again, this is almost set. We have a meeting right after this call to finalize it. But so the reason why there's child terms and A and child term B is as we work in Gravity, especially as we consider any of our build, we have to establish the relationship between our concepts logically. So it's true of the child is true of the parent and vice versa. So transportation insecurity is the meta term here, the parent term, and you can see we have a child here, transportation insecurity, inability to access health and social needs. And then there's children of that term, that's the child term B. And then there's a bunch of other child terms A, which are on the same level as transportation insecurity, inability to access health and social needs. A lot of our literature, again, very, very grateful for our robust subject matter experts that include community assessments of transportation insecurity. So IPEC Center whether she's from UT or Texas A&M, I'm trying to remember, she's so brilliant. She helps us a lot with some of the community perspective and research regarding public transportation and elements of captive riders. So this is the diagnosis as they stand. So again, what do we have so far? We have these screening questions and answers on the previous slide. We have these diagnoses. And again, please review the master as it comes to light over the course of the next days. And definitely by Monday, you should be able to go to the Gravity Confluence and see that. Next slide, please.
Sarah?
Yeah, hi.
On that previous one,
Mm-hmm.
is it totally out of scope for us to be concerned about, how shall I put this, environmental impact of different transportation options?
You mean in an environmental wellness perspective itself, insofar as like
Yes,
footprint and pollution?
yes.
It is not out of scope in general for gravity work, as we specifically discuss environmental, like neighborhood and social elements later in 2021. It is out of
Okay.
scope similarly to how food access or food deserts are out of scope right now. We're out of scope for food insecurity because right now it's the, well, again, one could imagine one can imagine a scenario where this is where it wasn't out of scope, but for right now, we've created space that we're considering that in community assessments of transportation security as opposed to individual. And maybe that's not correct, but that's the way we've approached it so far. Does that make sense?
I think it would be good. Imagine in a year or 14 or 18 months from now that we overlay everything that we've done from a pure environmental impact, that is global warming impact assessment.
I think that sounds brilliant.
We could do a matrix where
Yeah.
we discover that a lot of the screening that we do is producing unlooked for, unwarranted impacts on the environment, not to mention that outcomes
Mm-hmm.
we would want to be consistent with a much broader framework than we can actually bring to bear in these meetings. Thank you.
I love this idea. And one of the things we do think about at Gravity is the concentric rings, like different perspectives of whose wellness are we assessing, right? Wellness of the individual, wellness of the community. I think ensuring we consider wellness of the environment in our perspective is an ethical mandate. So, yeah.
Sarah, can I lift up, this is Mark, can I lift up an example from what I'm seeing on the screen?
Yeah.
So excessive time spent traveling. There are different reasons why somebody might be taking the bus. One reason might be because of the environmental footprint, but that may also produce, given the inequities in the distribution of busing and bus schedules, that might definitely shape the answer to excessive time.
Yeah, and then one of the things specifically that we were considering calling out as a child term B was excessive time spent traveling to medical appointments, like specifically regarding how to represent whether that would be a transportation element or a healthcare access element that would be considered in the community perspective. We did go back and forth about that. Yes. Good thing these calls are recorded. We'll add to the, we have to model, I do have a model of the intersection of personal food insecurity and community food security, and maybe we can try to model some of the intersections of wellness as well. Thank you, amazing people. Okay, next slide, please. And Margot has totally agree, really important to address environmental footprint as well as environmental racism, and Carrie echoes the same. Certainly as we consider racism in necessarily, that is, we can't neglect to think that as well. So coming soon as well, updates to the goals and interventions. As you all remember, I had a specific call to try to help us out in creating the programs that are used to address these domains. We had a huddle. There was a go out and kind of be like glean whatever you could from the community and come back, and we're integrating those elements into our approach within interventions, and you'll be seeing those as we go forward. Again, whenever anybody sends a program, it's really important to try to send a definition if you can. If not, we'll be querying you and querying submitters for those definitions over the course of the next days. Again, weeks, I should say. Again, looking forward to vote on 2-4. And Carrie, we can huddle specifically on how to support the community health centers you're working with. Next slide, please. Oh, and this is for Lucy. This is the transportation brain cloud. Next slide, please.
That's adorable. Thank you.
Yeah. Next slide. Oh, any questions as we finished transportation and security? Okay, now heading into financial insecurity. As you can see, we're trying to lay the groundwork for where we are for these domains and the work to do this month as we go forward and try to aim for that vote on February 4th. Okay, next slide. I wanted to just put onto into the community's mind kind of the evolution of the thought regarding financial strain as a domain that was based the process of the subject matter experts, Dr. Adam Shigadans and Dr. Jeffrey Colvin, and myself over the course of many late night calls and many emails. As you may remember, financial strain was the domain that we kind of put in the timeline to be addressed with the Gravity Project. We were thinking at the time about the IOM perspective, but also about the cardio screen perspective, which really is a measure of financial stress. In working with our subject matter experts, it became very clear that that perspective was too narrow to encompass the risk of the literature and the expertise that they represent, which is fairly vast. So there's two considerations here. So number one, financial insecurity is generally the parent for almost all of the domains we've addressed so far. So if financial insecurity is a comment, and this is as a parent is a domain, and this is not financial strain, this is just financial insecurity, you can imagine food insecurity, housing insecurity, and transportation insecurity being children of them. That's not represented on this slide, because all I'm talking about on this slide is where we are within the comments, within the terms we're talking about within the financial strain domain. But in working with subject matter experts, they asked us first to piece out two different elements of the domain. One was financial insecurity, which includes concepts of financial strain, debt, and medical cost burden, and others. And one was material hardship, which is disconnected. It's intertwined with, but not specifically dependent upon financial insecurity. For instance, one could be unable to obtain utilities because of living deep in the Navajo reservation, as opposed to not being able to afford your bill. The outcomes are the same or similar enough that they are from the literature grouped together. So the subject matter experts basically expanded and kind of exploded the domain into these two different wings. So we have financial insecurity, which again includes financial strain, which is best represented by some of the financial stress and financial wellness questions you'll find on the master list. And again, that cardio screen, specific questions regarding medical cost, which we know from health leads, and then some debt questions, which come from federal economic wellness approaches as well. And then material hardship over here on the right. So we did not intend to address material hardship necessarily. It was just became like an ethical obligation. You'll remember this from the ICD-10 submission, right? So in material hardship are many of the things we've had in PARC so far. And I say this just to call to light. So we have to figure out how to include this work responsibly in our timeline at this time. So we had talked about digital inequity being a concept for late 2021. You can find that concept contained within inability to obtain internet within a child of material hardship. We had talked about utility inequity, and you can see that in inability to obtain utilities. Inability to obtain childcare is here as well. Many of the screening questions and answers that we know that are widely disseminated, such as questions from Prepare, for example, lead you directly to elements of material hardship. I could not get X, right? So we have to we're working right now to figure out how to ensure this work happens in our 2021 timeline, whether it happens right now and we just extend it and keep on going is one consideration, but it's just important to call this to light as we go forward, because really we're asking for submissions regarding both of these wings at the same time. Any questions? That's a lot.
Sarah, I think inability to obtain childcare prompts the idea that there's another child here for material hardship. which is inability to obtain home health services. Because childcare is obviously an age-related dimension of that, but you could be, in the sandwich generation where you can't get to work unless you can get your dementia-prone parent taken care of or watched over. So inability to obtain, I don't even know what the right word, home health is
Home care, maybe. Yeah.
home care. Home health is too narrow.
Home
So
care might, yeah. 'Cause home care would include a PCA, right? And it would
yes.
include, okay, so lovely point, Lucy, or caregiver support like that, Deb. Hi, Deb. So I think if
I
we go
like
to the
that
next slide,
caregiver. I like caregiver support.
I like that too. I really do.
Thank you.
Yeah. So if you go to the next slide, you can see the boundaries of this in our definitions, right? And I think this actually, Lucy, fits right in, right? You can tell I'm working with two pediatricians as a subject matter experts. So thanks for helping. So the definitions, and these are pretty solid for financial insecurity and material hardship as they stand, are financial insecurity is a state of being wherein a person has difficulty fully meeting current and or ongoing financial obligations and or does not feel secure in their financial future. And the material hardship, again, you can imagine this being related to or because of financial issues, but not necessarily is the lack of specific socially perceived basic physical necessities. And physical is actually in process here because these elements are not all physical. So we're trying to wordsmith that a little bit. But you can imagine that caregiver support would be entirely appropriate here. So this is the kind of the bumpers or the guardrails of our conversation as we go forward, and that seems to be quite appropriate.
Another thought here, Sarah and everybody. I'm trying to relate this conversation to a conversation that we're all so familiar with, which relates health status to income. So I think what's going on here, we're trying to separate insecurity and material hardship from actual income, because financial insecurity can occur at many income levels, and lack of specific socially perceived physical necessities seem to be related to poverty, but may not be. So
Exactly.
I think that the definition somewhere, when we eventually publish, we should say that we are separating these concepts, these domains, from income level per se, although it may turn out that they're correlated, but that's not how we're thinking about it.
So I think similar to the conversations regarding intimate partner violence and housing, right? One can imagine. So we actually literally were passing back Venn diagrams as we were defining these things by email over the course of 2 weeks. So these things can overlap. They can be present at the same time. They can be not present at the same time. Income can be a factor, or it could not be, right? So we are having lots of conversations regarding income right now as well. But definitely this space specifically was created to call out those elements where income is not a requirement for inclusion in the category. So Lucy, you're correct there, because we would miss much of our population if it was based on what we know from the literature and from
I'm just suggesting that I think it should be stated, because when people think of finance, they immediately think income, and we are moving beyond that. We're transcending that. We're expanding it, whatever the right verb is.
You're suggesting
That's
like
not where we are.
Not dependent, not necessarily dependent upon income level comment.
Right.
Okay.
Right.
Got it. Okay, so please consider access to resources and to access to other information. So Brian, help me understand what you mean here. So can you unmute yourself? Maybe it's too
Hi.
hard to.
Yeah,
Hi.
I go back. Hi, good afternoon. I kind of go back to your initial concept of knowing that these are somewhat interrelated. But on that same note, when I mentioned access and knowing that they're interrelated, for example, if someone is homeless, then they don't have a mailbox, they don't have access to things. So even applying for some sort of assistance would be difficult. So I'm just kind of leaning that way, and I just threw that out as food for thought.
I love that. No, I love that. I think because what we know in clinical care is risks overlap to increase risk, right? And so part of the thing we think about with our diagnoses is really to address interventions, right? So if one is if one is homeless and does not have, a mailbox in order to get like a license, right? Because you need to have mail to a certain location, right? You can imagine material hardship being the intervention, but homelessness being the driver, right?
Yes. Yes.
So I think that's really important to call to light, and thank you.
Thank you.
Yeah. And then Rita was asking, how do you think of the overlapping concepts such as risk of eviction due to inability to pay rent and financial hardship? Do you mean so Rita, would you like to unmute yourself so I can hear you?
Hi, Sarah. It's Rita.
Hi, Rita.
Here. Yeah, no, it was just a basic question, because I know, like some of the MCOs that we're working with here in DC, like they ask some things, not all of them, they ask some things like around that focus on like financial situations, and also at potential risks around like things like eviction with regards to like housing, or like losing utilities and that sort of thing. And so I was just curious as to, I don't know if this has been covered previously or not. I wouldn't be surprised if you have already, so I apologize if it's repetitive.
No, I think it's really important. I think if you have a question, I'm sure other people do as well, right? So that was largely those concepts regarding housing, specifically risk of eviction or inability to pay rent, were the reason for the creation of the housing instability domain as distinct from homelessness, to cover what we know of the literature regarding housing, like the tenuousness of housing and its associations with its own health risks outside of homelessness. Again, one can imagine that housing instability is a child of financial insecurity, and you can imagine all kinds of other reasons, that one would have many of these things at the same time. But you are correct to call it out as something that's critical. We have tried to address it in our housing instability approach. But again, you might be positive for a couple of these things at once. Is that helpful?
Yeah, I mean, I don't know if this is the type of thing that you've noticed in the screeners that you've evaluated, or if there's even formal ways to like represent them, through screening and to arrive at a particular, I guess, condition or observation, how you guys look at things. But
yeah, so this is the heart of the Children's Health Watch housing vital sign question and answers. Those 3 critical questions regarding multiple moves, trying to remember all of them. But so Rita, I'll share those with you. And then the amazing thing too is a lot of these questions and answers, when we think of our federal partners, they might not be in our screening ecosystem that we know clinically now, but they're very much within the HUD approaches to the development of their housing security module that will be the mirror of the food security module. And those questions and answers are, again, part of our data set already. We stole them even before they're public. So mapping the diagnoses we're suggesting to questions and answers that are in the ecosystem should be easier once these questions are out there in the world.
thank you.
And you and I can talk about this at length anytime.
Oh yeah, thank you.
Okay. I know. So Jenny's so our friends over at ONC and Medicaid put out a little letter regarding the Gravity Project today. Thank you so much, Tom Novak. That's just lovely. I know. I've gotten texted about that a couple times in the last bit of time. And then Doug, do we envision mental health interfacing with SDOH? We do. Certainly it does, because it's a lot of the literature on health risks regarding mental health. So we do, because we talk about, this is really all about humans and people, right? So again, as much as we try to sort these things to name them in our work, they exist in a complex, gorgeous cacophony in the humans we care for every day. I'm rural family practice most days of my life. So we absolutely do envision that. And I can imagine some really interesting literature and coming out of the capacity to do each of these things, assess social risks a little bit better. Is lack of will we capture strengths such as existing of social networks to offset needs and weaknesses? Yes, we will. And there's some slides about that in a section in a bit. And if you have things to add to that regarding protective factors, I would love to have you be part of that conversation, because that's a conversation that needs to be had. We are having it, and we need to have it better, and we will continue to have it, because we do not want to be have a negative perception only of the people that we care for. Right, our risks are the ships we ride. I mean, our protective factors and assets are the ships we ride on. So, is lack of address a housing and stability question? Maybe Lucy, you and I can. I don't know if I know what you mean there.
I have learned in the last couple of months that there are actually committees meeting about how to deal with the concept of patient address. And I think we all may remember when there was a lot of controversy about who can vote or not, or whether you can register and so forth. If you don't have an address, can you register? And the answer has to be yes. So when we were talking about basic physical necessities, I was suddenly wondering about the concept of address. And if a patient comes in, it would be wonderful if we had someone from the Indian Health Service on this call to talk about people who come in regularly for care who are not accessible via an address to mail to, and whether that matters and how they deal with it.
It definitely matters from an equity and disenfranchisement perspective.
Yes.
So it matters. And I mean, I had 2 patients this week in rural Vermont who don't have mailing addresses because they don't live in places that have one. So,
I don't know if that's relevant for healthcare, but
it is.
So let's talk about it. Okay.
Yeah. So I think let's place it in our little parking lot and figure out where it sorts. Unfortunately.
Thank you.
Sarah, can I throw out a comment?
Yes, please.
So address is currently coming up in patient matching conversations, thinking that standardizing address may be a low-cost way to try to help in that effort, although it doesn't completely solve it. So just noting that cross-current and just highlighting that mailing address and physical address are 2 different things. And I think Lucy's example of Native Americans illustrates some examples in my mind where there's not even a need for a physical. I mean, people moving around and just living off the land, and so there's not a physical address nor a mailing address.
Yeah. So I think.
Yeah, I've been in meetings where the concept of address starts to take over the conversation. And so the resolution of the dilemma is give us the address if available, quote unquote.
But then we specifically think about what was happening with some of I think it was North Dakota and voting this year.
Yes.
So it was like, so I think, okay, that's something I think we definitely need to figure out. And, in each of our conversations, when we recognize we don't necessarily have the representation in our leadership to be even begin to answer this question well, like from either a lived experience perspective or we are always in charge is pause and make sure we have the right people at the table to do that well. So Lucy, hearing you regarding Indian Health Service, and we'll reach out there and just want to give note to that. So we do have lots of friends in that work, and we'll note to self, note to team to reach out and make sure we do that well.
That's great. Thanks. And also note this comment from Carrie.
Yes. Yeah. Fascinating.
That's completely wrong.
Well, yeah, I
Or
know.
at least in some cases, it could be completely wrong. Okay.
Well, in each of the two real humans I saw this week, that would be wrong, right?
Yeah.
Yeah, very much housed, just not with a mailbox anywhere near their self. Okay. Okay. So thank you, Carrie. Thank you, team. This is such a lovely conversation as always. Okay, so this is I think we're going to keep on going again. 5:10, we have 20 more minutes. We're definitely using our whole hour and a half. Linda, when I went over the slides with her at 1, she was like, woo, it's a lot. I'm like, I know, we have a lot to do. So next slide, please. So I just wanted to highlight, so unintentionally, basically what that slide says, we increase the range of the initial domain of financial strain by really from an ethical perspective, because our subject matter expert says we have to address this. We just might have to adjust the timeline to compensate, which means maybe material hardship elements extend beyond that February 4th deadline. However it happens, we're just going to figure it out in time, but just know we're committed to completing that work. We just want to acknowledge from an agile project management perspective, we have to adjust. And then Carrie, I'd love to have that conversation with you. Okay, next slide, please. Just wanted to go into existing financial insecurity material hardship screening tools. So this is what we have so far, a lot. We have Health Leads Prepare, North Carolina Healthy Opportunities, American Housing Survey, Accountable Health Communities Tool, AFP Upstream Risk Tool, BMC Thrive, iHelp, Patient-Centered Assessment Methods, CFPB Financial Wellbeing Scale, WellRx, FENEX Chronic Stress Elements, which again include financial stress as a question and answer component. FENEX is really adaptable for pulling out individual elements because they group things in themes. It's not just a panel, it's like a question theme. So we pulled those out. We Care and the Children's Health Watch tool, Medical Expenditures Panel, and Your Current Life Survey. A lot. Right, and so you'll be able to find those again on the master list in the screening questions and answers section. There are more to come as we do our audit of all of our comprehensive screeners. And again, we are considering how to put income in here again, because income might be a separate element per se, but we're having conversations regarding income as a domain and how to consider that as well. Whew. Next slide, please. Any questions? So we've covered inadequate housing update, transportation insecurity update, and financial strain material hardship update. Again, the work for all 3 of those so far, at least for financial strain, is to try to do everything from screening questions and answers all the way to interventions. And to see what we can do through the end of this month. There's already a lot of material there, so it's really just reviewing, collating these master lists, making sure we're all in agreement, and then voting them on in February 4th. Next slide, please. Okay, so specifically a focused intent regarding education, unemployment, veteran status, just on screening and diagnoses. If you'll remember, we already came to consensus regarding our approach with ICD-10-CM, which is kind of the meta-diagnostic approach. So our agreement on just screening questions and answers and diagnoses, again, this is just for now, was the dotted line, but this is to make sure that we are meeting some of our obligations with our existing contracting partners, just to get these elements done by the beginning of February. Next slide, please.
Sarah, why is veteran status a domain?
Because being a veteran is a risk. It's its own risk.
What about being in the family of a veteran? Is that included within this domain or concept or thinking, and does it matter?
It is not included. It is adjacent to. There is definitely literature regarding the families of armed service members. Absolutely.
Certainly mental health issues.
Yeah, 100%. But again, right now, it's on the veteran themselves.
Okay.
And then we would definitely consider talking about armed service families in the future. 100%. So it's on here because it is independently in the literature its own health risk. It's a risk for many of the social risks we've talked about before, specifically considering homelessness. We know about the literature regarding mental health, depression, anxiety, PTSD, suicidality. It carries a lot. And so that's why it's here. But again, we're doing this gleaning process across all of our comprehensive tools. And in the process, in this audit, we revealed, again, across specifically these demographic elements, a need to bring in, again, some of the federal approaches to screening for these questions and answers to ensure that they were included, because you can't do the current population survey or the food insecurity module without indicating education and employment status. And veteran status is, of course, a very important consideration from the VA perspective. So just ensuring those screening questions and answers are robust as possible. And so we're asking you to, again, look at those elements in the next week or so, and just to review and prepare for a February 4th vote. The diagnoses are largely settled because they're quite straightforward. They're kind of a binary yes, no. But the screening questions and answers are fairly diverse. And we want to make sure everyone's aware of them. And then I think that was this. And so again, focusing just on screening questions and answers and diagnoses. And then so next slide, please. Whew, any questions? All right, next slide. This is where I wanted to bring in, I'm trying to remember who brought to light protective factors. We're just going to briefly talk about where we are with goals. I want to refresh some of the conversation we've had in the past regarding goals. And we paused some of our goals conversation in order to prepare for the Connect-a-thon, because that work was happening in the same meeting. Oh, thanks. So I wanted to get everyone on the same page again. So next slide, please. So we are working both with our community and with HL7 Patient Care Workgroup on developing consensus for goals across the ecosystem. And one of the things I've been raising in these meetings, and again, this is reference to a comment earlier in the chat, is the relationship between goals and protective factors. So the definition of a goal is a desired state. And in some sense, up until recently, we've been imagining protective factors as like a separate build, like a domain themselves. But in some sense, you can also imagine at least preliminary build for protective factors by the balance of the risk. Because again, our determinants are not all risk. Some of our determinants are positive, and they're called protective factors. So for instance, you might be low income, but food secure. You might be unhoused, but be very socially connected with a group of people that you feel seen and heard by, right? So if we consider social isolation, social connectedness is protective. If we consider unhoused as a risk, being housed is protective. So although the meta goal as the protective factor is a little bit hard to measure. So from a measurable goals perspective, there might have to be sub goals underneath there that we consider. We are raising the conversation regarding come to agreement on these kind of positive statements and coming within terminology as representing this protective factor element. Does that make sense? so far. And again, no final statements here, but it's literally just trying to have these conversations thoughtfully. And if anybody wants to have them with us, please let us know, and we will have you come to these meetings so we can have it all together. These meetings are open, and we would love to have your participation. And there's just a special little meeting apart from this meeting together. Next slide, please.
Sarah?
Yeah, hi. Hi, Lucy, my friend.
You're saying next slide, please, is a prompt for me to ask a question about the slide that you want to
I
get
love
past.
that. Should we go back?
Okay, sorry.
Okay.
Please go back. I'm thinking about being a patient, say for the first time somewhere, being questioned about social risk factors.
Yeah.
And I might really understand why I'm being questioned about that. So then, are you going to take another 15 minutes asking me, what are my protective factors? Is that language that caregivers actually use when talking to patients? And if not, what is the language that's actually used to elicit what the patient thinks can be built on?
Usually it's strengths, right? Or assets. And it's 100% part of effective assessment and care management and social work. I don't know how many social workers we have. Again, I am sad to say, as a primary care clinician, I don't get to do this part of the work as much as I want to. But when I think about making an eco map of a patient and their ecosystem, right, and their risks and their assets, that asset assessment is pretty crucial. So we think about it in terms of strengths. We think about it in terms of, again, assets, as I said, and then in the literature, they're often known as protective factors. One of the leaders in this work is the amazing group, the Camden Coalition. I always kind of refer to them. And when Carrie was talking about iconography, I raised they have an iconography approach called Camden cards, which are just pictures of, you lay out all the different things that are critical for the patient. And they literally use an image to guide what's first for them. Like, out of all of these things, legal is where I need to go, where I need the most help. So this is definitely the kind of non-linear. I don't imagine a future where you'll get a screening. Maybe there is a future where someone would give a screening question and answer for protective factors. I know actually those assessments exist, but really these things happen in conversation, and they happen in conversation in a visit too. Like I do substance use disorder treatment and medically assisted treatment as a rural practitioner, treating folks with substance use disorder, assessing the strengths that help keep a patient on the path to recovery are really critical. And I put them in my notes, and they're part of an ongoing assessment. Family, transportation, children, church. Yeah. Yes. Yeah, it happens. Lucy, was that a good enough answer?
Okay, thank you. I have certainly never been subject to such questions.
Yeah, so this is
Coming soon to a visit near me. Okay, thank you.
Well, I do want to say again, this borrows heavily from the field of social work. Like, I don't know if a lot of social risk may be new to the medical environment. It's ancient in the nursing and social work environment, and that assessment is usually narrative, exploratory. And we're codifying things necessarily because we're the Gravity Project, but I would love to talk to you about my geek out on all of those elements with you anytime.
Okay, it's a date. Thanks.
Okay. Yes, Carrie Nichols, it's the core community health center work. It is. Yes, community health centers and their embedded team-based approaches are critical in this. In fact, NCQA patient-centered medical home certification, assessing a patient's strengths is an element of success in being patient-centered as you look for patient-centered medical home certification. So again, usually these things are narrative and exploratory, but these things are also less transient. I mean, they tend to persist for individuals. So we tend to just assess them yearly or on with some degree of periodicity. And they're usually part of an intake. Like, who are you? Tell me your story, right? And let's gather this, like, the picture of you. And then we go from there. Okay, next slide, please. So this is really just trying to again, this is a work in progress about how action steps, goals, and protective factors might interplay. So you can see the risks are on the left-hand side here. And you can imagine their inverse are these positive statements. Again, it's not entirely like those elements are all protective factors, but they definitely are assets or strengths. And so it is reasonable to consider building this kind of balancing terminology, because you can imagine if you're trying to intervene on a subtype of transportation insecurity, like unaffordable transportation because they do not have money for gas. Giving a gas card helps move an individual from unaffordable to affordable, but their car might still be crappy, right? So you might not change all of the things. You can make plans on specific things. And so these subtypes of transportation insecurity and these possible subtypes of the inverse of them, you can create action steps that move you from one element to the other without suddenly, aha, you're transportation secure. And so how do we plan to deal with social factors that become risks only under certain circumstances? I think that's regarding one of the timing conversations we've been having, I think. And that's a process question. I think a lot of these questions might come up under implementation. So we're creating the language to test together. So I think that will be a really interesting thing to discover under testing and implementation and piloting. Next slide, please. Whew. Okay. Next slide. I saved up all my talking for a whole month, and then I just talked. So you can tell, I'm so sorry. Everyone, that was a long call. Thanks so much for bearing with us, bearing with me. So you can always catch up on materials and recordings on the Gravity Confluence page. We want you to submit concepts for transportation insecurity. Even if there's screening tools that you don't see there, please submit them. Submit concepts for financial strain, and then specifically regarding screening questions and answers and diagnoses, concepts regarding those, the education, veteran status, and employment. I have a to-do to work on that blog regarding the intersection of ICD-10-CM and E&M and social risk assessment. Art Davis is asking, is it really a protective factor or resolution of a need? Protective factors seem like something that we have in advance of the screen for a risk. I think the idea is, Art, is that we want to be efficient with our terminology development. So that same term that might be in a different situation employed as a protective factor could be employed in this instance for goal setting. So instead of, so if we're really thinking about, you know, efficiency in terminology request and terminology development, one can imagine like these terms playing multiple uses and being interchangeable. So in one instance, it might be critical to assess it early, and in another instance, it might be able to serve as kind of a meta goal for a specific intervention regarding a subtype. And again, who knows? This is just a work in progress. But basically, it seemed like an opportunity to consider protective factors and assets and strengths, not as future work, but as intertwined with the work of risk making. Thanks. Yeah, I'm a laugher for sure. This is what people know. So about me. So I'm so glad you all were here today. Next slide, please. And then join the project. Here we go. Welcome to 2021, folks. Thank you for being part of our 2020. There's lots of wonderful work together that we have to do over the next year. And thank you so much for being part of the Gravity family. And we'll see you in 2 weeks. And remember, please place on your dance cards space for that 128 meeting. We might have to move another meeting that's scheduled at the same time, but we need, I think, another meeting in order to meet some deadlines there. So we would love to see you then. Mark it down. Talk to you soon and see you in a couple weeks.
Thank you, everyone.
Thanks, everybody.